Welcome to another episode of LIMBWatch Series by Diabetic Foot Files, where we explore the latest advances, real-world challenges, and life-saving strategies in limb preservation. Today, we are very much honored to welcome Dr. Lady Paula DeJesus. She is a triple board certified podiatric surgeon with extensive expertise in diabetic limb salvage, wound care, and complex lower extremity reconstruction. She serves as the section chief of podiatry at Yale New Haven Health Greenwich Hospital. She is board certified with the American Board of Foot and Ankle Surgery, the American Board of Podiatric Medicine, and the American Board of Wound Management. She is a fellow with the American College of Foot and Ankle Surgery. Her expertise includes diabetic reconstruction foot surgery, wound care, diabetic foot infections, wounds, minimally invasive bunions, and hammer toe surgery and reconstructive foot surgery. Dr. DeSuze completed a 4-year surgical residency in New York at Wyckoff Medical Hospital or Medical Center, Wyckoff Heights Medical Center, forgive me, an academic affiliate of Weill Medical College of Cornell University and New York Presbyterian Hospital Network. She served as the solo chief resident in her final 2 years, supervising and teaching 33 other residents. Dr. DeSuze is a former faculty within the Department of Medicine at the prestigious New York College of Podiatric Medicine located in New York, New York. In addition to teaching, Dr. DeSuze exhibits research about unique surgical case studies at surgical conferences nationally and internationally. And Dr. DeSuze volunteers her time by participating in yearly overseas medical mission trips, such as in Vietnam, Colombia, and the Bahamas. So welcome, Dr. DeSuze.
Thank you for having me. I appreciate it.
Yay.
Yeah.
Okay. So what is the first thing that pulled you into podiatric medicine, and when did wound care become like a calling within it?
Originally, I really, was thinking about doing something with sports, so sports medicine, because I was an athlete in high school. But then, my uncle, he actually fractured his foot on the job, and at an early age in high school and college, he told me to see his podiatrist who was managing his fractures. So I did go shadow his podiatrist, and that was the first time I saw lymphedema that really blew my mind, because before that I didn't really pay attention to people's legs and feet. And I saw all sorts of things that dealt with the feet. And that's how I, got into podiatry. As far as wound care, that's truly, from my residency. I did my residency at Wyckoff Heights Medical Center in Brooklyn, and there was a major wound care center there, and I got trained there. We saw maybe 60 patients in clinic a day. So a huge need there in Brooklyn.
Okay, yeah, definitely. Was there a specific patient or case that fundamentally changed how you approach limb salvage?
Yeah, so this is probably in the past 5 years. I used to practice, what we learned through books and in residency. I had a patient who had previous amputation and developed ulcers due to transfer lesions, and I did recommend a transmetatarsal amputation to her because that's what I was taught. And she just refused. And in order for me to heal her, there's new technology now and new techniques through minimally invasive surgery. So now I approach my techniques through minimally invasive surgery, and I did that to this patient, and she actually healed without a transmetatarsal amputation. And from previously not being able to walk, now she walks miles and swims, and this is just through these little keyhole incisions. So it really changed the game since minimally invasive surgery has come out.
Oh, wow, that's amazing. So you've earned multiple certifications and fellowships. What part of your journey was the most difficult to navigate clinically or personally?
I think clinically it was managing patients in different cities or towns. I practiced in deep Brooklyn, and then I also practiced in other parts of the country like Florida and now Connecticut. So the patient populations are different, just trying to find out how to manage these patients because some of them are more needy or demanding and managing different communities and personalities, yet still providing top tier care. I think that was the most challenging. Just like that example I just gave you, the patient just totally refused transmetatarsal amputation. And I understand that. So it really was difficult to understand different types of communities. And I just had to figure it out. Personally, I didn't know where I wanted to practice. Did I want to practice in Florida? Did I want to practice in New York or the Northeast? Because I was born and raised in Florida. So that's what brought me to Florida. And I did end up practicing in both Florida and New York. I used to fly back and forth, and now I live in Connecticut and work in Connecticut just because I had a job opportunity. But at one point, I actually tried to find a job in Seattle because my brother lived there. And I decided I'm not a mountain person, so I'm not a West Coast person.
Oh,
belong on
wow.
the I belong on the East Coast. So that was my personal journey.
Yeah, I think you like the beach, right? You like, oh,
Yeah.
yeah, yeah, yeah.
I'm like
What
tropical. I'm not a mountain person.
what is the most common missed opportunity that you see in early diabetic foot infections or ulcers?
I think when the patients don't seek help immediately, despite me educating them, they know that there's an ER, they know that there's an urgent care, they know that there's doctors. You can easily call and see anyone, but they treat them and try to manage the wounds themselves. And a week can go by and they just let it be. And by then it's too late and it leads to an amputation.
Yeah. In your experience, what is the earliest turning point for where a foot goes from salvageable to a high risk amputation risk?
Poor blood flow,
Yeah.
and the patient not being a candidate for revascularization. I can't do my job if the landscaping is inappropriate, and also non-compliance. As doctors, we can help and manage the patients, but it's a two-way street here. The patient also has to be compliant. We are collaborating together to save their leg and foot, and they just need to understand that and work together.
Mhm. Yeah, I can agree with that. So, how do you personally decide aggressive debridement, stage the intervention, or escalate to surgery?
If there's an infection or non-healing tissue in clinic, I'm generally aggressive. I debride if tolerated, and I provide immediate care like antibiotics and daily wound care. But I also think about admission. Most of my cases are stage surgery, so infection control is number one. So performing infectious, I mean, INDs, debridements, maybe possibly implanting antibiotic beads or even a bone debridement, and then a stage surgery to possibly primary close the area or apply graft.
Mm. So, can you walk us through your mental algorithm when a diabetic foot patient presents with infection, ischemia, and neuropathy simultaneously? Trifecta.
Yeah, so that a lot goes on my mind when I see all of that. So immediately I'm ordering an arterial duplex to assess blood flow. That's very, very important. We can't do our jobs unless there's flow. I'm ordering an ESR, CRP, and a white count, hemoglobin A1C to check for sugars, X-rays, possible MRI. I'm also consulting vascular and infectious disease. We all need to collaborate to help the patient. Infection control, so I have to order a wound culture and antibiotics. And with neuropathy, we have to protect the foot with either a surgical shoe offloading, a cam boot, or diabetic shoes. And I'm also always thinking about possible admission because with
Mm.
admission to the hospital, things can be expedited. We can get an angiogram done right away to check blood flow. We can perform podiatric surgery if needed immediately. The patient can get immediate IV antibiotics. The patients are more prone to compliance because they're laying in bed, which means that they're non-weight bearing, and we can obtain imaging like X-rays right away and MRIs or CTs.
Yeah. So, what clinical signs do you trust the most that textbooks often underemphasize?
I think with this, we're taught a lot through textbooks, but we I think we don't really pay attention as much to pressure and biomechanics. and why are these wounds developing. We need to solve the biomechanics and also check shoes for rocks, pebbles, and debris that can cause wounds, because a majority of our patients are neuropathic and they don't feel anything, which if there's a rock or a pebble in the shoe, they step on it, they can get a bone infection and lead to amputation. But biomechanics is key. In school, I didn't really enjoy biomechanics, I'm going to be honest, but now I understand the very much importance of it.
Yeah, no, it's very complex, and no, it makes sense now, yeah, when it comes down to, like, other things. So,
Exactly.
when how do you balance imaging when it comes to, like, MRI, vascular studies? What do with what you see physically compared to what you feel at bedside?
So first of all, I am checking for pulses if they have non-palpable pulses or diminished pulses, and if the skin is shiny, you notice that there's no hair growth or even necrotic tissue. Obviously, you're immediately ordering vascular studies, and I do order vascular studies every 6 months because things can change very quickly.
Mhm.
And if the wound is probing to bone, if I feel fluctuance with redness, or if the wound is just not healing, or if I feel like I need to take the patient to surgery, I will order an MRI.
Mhm. So, what are the most misunderstood aspects of diabetic foot osteomyelitis today, in your opinion?
In my residency training, we were taught for osteo, patients need IV antibiotics for 6 weeks. Nowadays, I see infectious disease prescribing oral antibiotics for 6 weeks, and it works just as well. So I
Mhm.
think that that's misunderstood there. There are research papers out there that say that oral is as good as IV. Some patients, you really have to think about their life too. They they can't go to the hospital every day for IV antibiotics, or maybe there's a barrier where a nurse cannot go to their house
Mhm.
for IV antibiotics every day. So oral is still, as a benefit, just as good as IV antibiotics.
Mhm. Have you ever had a case where all the data indicated amputations, but you still saved the limb?
Yes. I had a patient who had forefoot gangrene
Mm.
and a large heel ulceration with osteomyelitis, also with PAD. They came to me for a second opinion because the previous physician recommended BKA. But we saved the leg first. Of course, there needed to be revascularization. After that, I did perform a transmetatarsal amputation. And there is a new technique called an Avedis suction curettage. So it's a keyhole incision to the calcaneal bone where you can curettage the infected bone through a suction. So that's what I did, and I implanted antibiotic beads into the calcaneus without performing a partial calcanectomy. I also applied skin substitute to the wound base of the large heel ulceration, which was granular and healthy. And about a year later, the patient did heal. Of course, that the patient had to start walking in a crow boot for function, but they did not undergo a BKA.
Mhm. So you said a partial connectomy, right?
I did not perform a partial
Oh, you did
calcanectomy.
not. Oh,
No.
wow.
Yeah, typically, others would have tried a partial
Yeah.
calcanectomy. This was a minimally invasive surgery through a keyhole incision. It's called the Avedis suction curettage.
So you kinda, like, just scraped around the bone and removed, like, the biofilm that's on the bone?
No, inside the bone. So
Right.
you make a small incision with a 15 blade on the lateral aspect of the calcaneus. There is a tamp that comes with the system to break the cortex of the bone. And then you insert this little needle through the hole into the calcaneus and debride the bone out. So essentially, you're coring out the calcaneus through this little hole. So you're removing the infected bone through the hole through the suction. And then after you debride all of the infected bone, you can implant antibiotic beads into that hole. So it's giving direct local antibiotics to that area. And that's how I manage that patient rather than doing a partial calcanectomy, which could
Yeah. Yeah.
cause non-healing still. Partial
Yeah.
calcanectomies are tough.
Yeah. Wow, that's amazing, Dr. DeJesus.
Mhm.
I have a question, another question.
Yeah, sure.
Yeah, about this case. So how did you have to use any skin grafts or anything?
Yep, use a skin substitute on that heel ulceration itself on the patient
Yeah.
aspect, and that healed well. I mean,
Mhm.
it healed. So the patient
Yeah,
was able
yeah.
to walk in a crow boot.
Uh, Hold on. He was able to walk in the crow boot
Yep.
all during the treatment
No, no,
or the
after 1 year, after 1 year.
after 1 year? Okay,
Yeah.
so he's like non-weight bearing for a year.
Yes, yes.
Oh wow. Okay, okay. That's awesome. That's
But
incredible. Mhm.
yeah, but we saved the leg, and with
Yeah.
statistics, if they underwent a leg amputation, they passed in 5 years. So
Mhm.
a huge deal.
Yeah, wow, Dr. Davis. Yeah, no, that's incredible. When do you choose long-term antibiotics versus surgical intervention, and what factors to help you decide that? But I mean,
Yeah. So usually with just small toe ulcerations that probe to bone and I obtain a bone biopsy, I can just debride that bone in the clinic and do long-term antibiotics. But other than that, larger wounds, I am very aggressive and perform surgical intervention. Amputation will always be there if the toe ulcer does not heal. I just want to give the patients an opportunity, to save the toe.
yeah, to try, yeah, to
Hmm.
see if it can. What infection cases keep you up at night even after treatment?
Nothing keeps me up at night anymore.
Oh, wow. He has found peace. Wow.
No, 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 no. Well, in the beginning of my career, yeah, I used to stay up at night with patients who I just perform neck fash surgeries on.
Mhm.
But really now it's not about the infection. It's really about how the patient's world has changed. I think about the patient as a person. So their
Aw.
quality of life, they can't weight bear momentarily. What are their limitations physically in the future, even if you heal them? I think about them not being able to walk barefoot at all, even on vacations. Some people want to go to the beach or pool and they cannot even walk on the beach or pool without sandals or shoes, or they cannot even walk on the beach. I think about their emotional toll, not only for the patient, but also for the family and the caregiver. I see patients every week in the wound care center, and it's not just about the patient, but about the caregiver too.
Mhm.
So we these weekly visits, you spend a lot of time with the patients, and it's just an emotional journey with the patient. So that's really what keeps me up at night. I think about their desire and goals of being able to just walk or standing to wash a dish. Those are the things that keep me up at night, not about infections.
Oh, can I just, like, mention a side note
Yeah.
that I remember specifically about you is I remember one time I was on call and we had a really bad, like, neck fash infection, and it was, maybe around, like, almost 1 a.m. or whatever, and, like, I'm telling you 'cause, it's for you, and I just remember you saying, "You're gonna be here in, like, 5 to 10 minutes," and I was like, "What?" And yeah, and I'll never forget that. I was like, Dr. DeJesus is like, she's that girl. Like, you came in and did that surgery, like, right away. Of course, they cleared him, like he's MPO,
Yep, yep,
but like, we were there. I think we were in the ER around like 3 or 4 a.m. And
yep.
you were like awake too.
Oh yeah.
And, and and you're like teaching me, and I was just like, how is she? I was like, "Why is she not mad at me?" Like,
Oh, oh.
Yeah. And I was just like, it was incredible, and after seeing that you did that, I was just like, Dr. Daces, like, she would never give up on a patient. That's what I always remembered about you.
That's a nice story. I like that. Yeah.
Yeah.
I remember those 3 a.m. calls.
Yeah, you were like, the one to call for that. You won't let a patient go. You won't, you're like a
Yeah.
superhero, like
Yeah.
Batman for, wound care.
Yeah.
Okay. How early do you involve vascular surgery in your workflow, and what does too late look like in real time, in your opinion?
I always get vascular surgery involved immediately. We work together in the same clinic, and we see patients together, which is a blessing for patients. So once I order a vascular test, if that comes back abnormal, if there's gangrene involved, if the patient has pain at night to the foot or leg, all the physical exam signs, as in shiny skin, no hair growth situation. Again, we as podiatric physicians cannot heal wounds if the blood flow is not there. So I need vascular surgery to do their thing first, and then I can do my thing. Too late to me means leg amputation. I would say, high risk is rear foot gangrene. Once the calcaneus is affected, those are tough.
I completely agree. It really is I agree with one of the doctors. They were saying how much of an indicator it is of mortality risk even, when they have that heel ulcer, that deep heel
Yep.
ulcer, it's a really big deal.
Yep.
In your opinion, what does an ideal limb salvage team look like in practice, not just in theory?
I think the ideal limb salvage team must include a therapist or psychologist because the patients are ongoing stress. This is weekly visits. It affects quality of life. It affects family members. The team also needs to include a social worker. They can determine if they need help at home, if the patients need other things, a vascular surgeon, infectious disease, a hyperbaric specialist, obviously podiatrist, a physical therapist to help with gait training. We need an orthotist on that team for braces, orthotics, offloading things, and an endocrinologist. We need an endocrinologist to help these patients control sugars. And if we had a clinic with all of these specialties all under one roof at the same time, it would be amazing.
Mhm. Yeah, no, definitely. And it's working together too. Like everybody has to be nice to each other. You know?
Yeah.
Like, yeah, yeah, like I don't want to be like texting the person and they're like, oh my gosh, like let it go. And I'm like, you know?
No, it would be great if we can all see the patient if they need it,
Yeah.
together in one visit. That
Oh,
that would be the ultimate practice.
so like, hold on, sorry. So like a Henry Ford assembly line?
Yep,
Oh,
exactly. Just boom, 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 boom. That's it.
oh,
All
wow.
in one
That,
visit.
but you'll be there all day. But yeah, like, but it'll
At
be like
least
a
they
one
can at least they can get it all in one day though.
day. Yeah, it'd be like a full thorough. Don't they do that in travel tourism, medical tourism?
I'm
Like,
not sure.
I,
Actually, no, yeah, you're right. They do. They
they
do. They
kind of
all get
do.
on.
Yeah.
Yep.
So, what new technologies or therapies in wound healing are you most excited about right now?
Like I said, the minimally invasive surgery that's been out, it's really been a game changer in my practice. These
Mhm.
little keyhole incisions have changed the patient's life because they heal faster. And also for me, it's also a faster surgery. I'm not opening up, huge incisions anymore. And this Avedis suction curettage that I mentioned about
Mhm.
calcaneal osteomyelitis, that it is a huge game changer. I am not performing these connect, uh, partial calcanectomies anymore
Mhm.
that don't heal.
Yeah.
The suction curettage to this keyhole incision, it helps heal these heel wounds.
That is so incredible. Like, that's why I was just like kept on asking you questions. I'm like, hold on, hold on, hold up. You know? Yeah. Wow. Are in your opinion, are we overusing or underusing advanced imaging in diabetic foot care?
I think we're underusing it. For some reason, some people they don't order an MRI right away if
Mhm.
they are trying to manage osteo, or we forget to take serial x-rays because things can change very quickly in a few weeks with osteosarco or infections.
Mhm.
I think we're underusing it. I think that we need to remember that that's there and not just taking wound cultures and physical exam.
Mhm.
The advanced imaging, their roadmaps to help us.
Thank
I think that we need to remember that.
thank you. Thank you
Mhm.
so much. No. So, how do you feel about biologics, growth factors, or in regenerative medicine in the real world practice?
I love them. They're part of my practice. Like I said, I use skin substitutes. I also use adipose injectable fillers for wounds that are hard to heal on the plantar aspect of the foot. It not only provides cushioning, it also involves stem cells, so it helps your own body create your own fat in that area, and it helps assist in wounds because it's pressure relieving.
Oh, wow.
Mhm.
Is it just like one injection or is it a series?
Just one
Just
injection.
one?
Mhm.
Oh, wow. That's
Yeah.
awesome.
Mhm.
So, how do you communicate to a patient the amputation risk without them panicking while still ensuring them that this is urgent or the urgency of the intervention?
So first and foremost, I express empathy and care, and I prepare the patient about what I'm about to say to them because I tell them that I care about them and I do care about their life. So that is what I say first. And then I literally tell them that they are at high risk of losing their leg. And if they lose their leg, they may die in 5 years per statistics. The patients don't panic when I tell them that. They understand the severity. And sometimes, tough love is the best love. You can't sugarcoat this. This is about their
Mhm.
life.
Mhm.
This is about, their future. And I say it every week. But again, I tell them ahead of time that I care about them and this is why I'm telling them.
Mm, because I feel like a lot of people don't there's a lot of patients, and they just don't feel like people care about them. They feel like a
Yeah.
number, so that's like it really makes a difference, and I feel like they're more compliant when they feel like you care.
Yep. And also when you warn them that they're going to die, I feel like the patients they're they think that I care about them. I
Mhm.
not that they just think, but I do care about them, but they perceive it as more that I care about them because I don't want them to die.
Yeah,
Not something to you know, make them,
not fear-mongering, like,
yeah,
yeah,
like
yeah, yeah,
stress or something.
yeah,
It
yeah,
shows that, wow, this doctor really cares about me because they're really telling me I may die, you know?
yeah, like,
Yeah.
informed, fully informed to
Yeah,
make the right decision.
exactly.
What do you think diabetic patients mostly misunderstand about diabetic foot ulcers?
Oh, gosh,
So much.
this is what there's yeah, yeah. What what is oh god, a pet peeve of mine is when the patients think that undermining wounds, they think that the wounds are getting smaller. So it's so
Ooh.
deceiving for them that they think that this overlying tissue, they think that the wound is getting smaller and that they think that debriding that it causes the wound to become bigger and it
Bigger.
doesn't heal. So every time, we debride, they think, oh, this doctor is just causing the wound.
Mm,
Why do they keep debriding that area when the wound is already small? So I think that's a big misunderstanding.
that is so good because I was like, that is a thing because like when some patients come to see me, they'll be like, "Oh, my last doctor, they made my wound bigger," and I want them to understand that's not true. The wound was
Yeah,
already big. The wound is bigger because of diabetes, and
exactly.
they removed all the tissue, like you said, the undermining, and that is something definitely patients have to understand, but what I've learned is, like, it seems like I always feel like I'm on a probation period with new patients
Yep.
when I debride them because they trust me more after they see that it gets smaller, like, in a week. When you do a really good debridement, they trust you, and then they'll know, like, "Oh, you're not just trying to cut me up just for no good reason."
Exactly. And also another thing, they think that bleeding is bad. When you're debriding them, they're like, "Oh my god, you caused me to bleed." But it's a good thing. You're bleeding.
Oh,
So I have to educate them that bleeding is good.
somebody once told me, "When you're red, you're dead." Yeah, that's what the person said, "When you're red, you're dead." I'm like, "No, but okay," you know?
Wow.
Yeah, yeah. But what's one conversation you'll always make sure to have with every high-risk patient? I think you kinda covered it with saying how much you care and their mortality risk.
Yeah, there's other things. I always tell them that we're a team. Me and the patient, we have to work together. I advise and give instructions if they can do their homework. That would be great to be compliant. They have to control their sugars. If their sugars are out of control, their feet tell me, because the feet tell me signs of their body. I tell them that all the time. They need to stop smoking. That is a huge thing. And with all these things, I always tell them that they're at high risk of limb loss. And again, that they may pass in 5 years.
Yeah. If you can redesign diabetic foot care from scratch, what would the system look like? I mean, you kind of covered that too with the assembly line.
Yeah, that would be huge. I'm telling you, that assembly line.
You heard it first, Dr. DeJesus, trademark,
Oh,
trademark.
no.
Yeah.
Oh gosh, I just gave away my secrets. Okay, but I think also though, the education, we need to educate the community about diabetic foot care, that it's not just about these so-called pedicures in their minds. They think that going to podiatrists, all we do is cut toenails. Even non-diabetics, they think that diabetic foot care is just trimming nails and getting a pedicure. I think it should be more advertised as it's limb saving and life saving, that it starts from the foot. It's not just about nails, it's about checking for wounds, if they have poor blood flow, numbness, tingling, all that kind of stuff, and all the things that come with it. It's not just about nails. Yes, we do that. I completely agree with doing that, because I do not want my patients cutting themselves by accident when they have PAD, because I've seen that happen and it leads to amputation. That is part of the package, but that's not the whole package. There needs to be a better way to educate the community.
No, you're totally right, Dr. DeJesus. So, Dr. DeJesus, what gives you hope in limb salvage right now?
The multidisciplinary approach, my headed forwards. That whole thing, multidisciplinary approach, and the MIS techniques, the advances. I can't wait to see where minimally invasive surgery takes us in the future. I think there's going to be a lot more advances, but definitely the multidisciplinary approach. I am a huge fan. I practice like that now, and I hope that other centers do as well.
What about the name Forward Foot Assembly Line? Yeah,
that sounds pretty good.
Yeah. It's a little bit of alliteration.
Oh, God.
What do you want younger clinicians to understand before they see their first limb-threatening case?
Keep calm. I know it can be stressful, but deep down inside, you were trained on this. You know what to do. All the signs are there. Remember the team approach. Don't forget to consult others. Infection control is number one. Worry about healing the wounds later, but infection control is number one. And also, don't forget about blood flow afterwards. The patient needs blood flow. Think about plants, right? Plants need water to thrive and survive. So does the foot. We need blood flow. And also treat your patients like they're your family member. If you do that in every case, everything will work out, and you just need to care.
I forgot to ask you this one question. Do you see any geographic, in your opinion, geographic or socioeconomic patterns in amputation risk?
No, money does not matter at all. It doesn't matter. Wherever you are, there's going to be diabetics who don't control their sugars. The risks are all the same. I don't see a difference at all.
You're lucky. Okay, well.
Money doesn't matter.
That'll be nice.
Unfortunately.
Okay, so now we're going to do our rapid fire. Yay. So, Dr. DeJesus, I think we kind of know this, but what is your favorite surgical instrument? I think we kind of learned
your surgical instrument. Oh, you mean the Avedis?
Yeah, now I think that's your new favorite surgical instrument.
Yeah. That's true.
They need to give you an endorsement deal, because you said that.
I know.
What's one clinical sign you'll never ignore?
Bullseye. I will, because of neck fash. I will never ignore that. I remember as an intern that I saw just bullseye on the foot, the leg was so swollen, and that was my first time seeing necrotizing fasciitis on physical exam. I will never forget that.
Wow. What's one, hold on, sorry. What's the most common mistake you think patients make?
That they don't check their shoes for these pebbles. I have so
Mm.
many patients, they walk in their shoes and they don't know that they have a wound a week later. And when they come to the clinic, I check inside their shoes and there's rocks and pebbles, sometimes coins, and it's causing these wounds.
Yeah, I mean, that definitely shows how bad the neuropathy is.
Hmm.
And yeah, what's one wound care product you couldn't practice without?
Antibiotic beads.
Yeah. I feel you with that. What's one lab value you always check?
ESR.
Yeah.
Yep.
What's one bedside test every provider should perform?
Checking pulses.
I
So
know, right?
simple. So
I
simple.
I totally agree. I feel like so much people could save themselves if they
Yes.
just use their hands.
Hmm. Even if the patient has an ingrown toenail, you don't jump to just doing a partial nail avulsion. You have to check for the
Mhm.
pulses. If they don't have pulses and you perform a nail avulsion, they won't heal. The patient's going to lose their toe or leg. So
Yeah,
you have
definitely.
to be careful about that.
What is the first surgery you ever scrubbed into?
The first surgery, I think it was. I remember I was a student. I was a third year student at Berry, and I did a hammer toe,
Oh,
second
wow.
digit. Hmm.
Oh, nice. Awesome. What's the best career advice you ever received?
Career advice. Career, we work not only to save patients, but also for financial reasons as well. So the best career advice was an attending once told me to live below my means. And in the
Mm.
beginning, put away 50% of your salary to build up whatever it is that you want. And then at that time, I wanted to go into private practice. And that's what I did, actually. I saved 50% of my salary and lived below my means. And I was able to open up private practice without business loans.
Oh, wow.
So
Yeah,
was never in debt.
you are such a great mentor and that you actually care. If you weren't a podiatric surgeon, what would you be?
A plastic surgeon.
Oh, yay. Okay. Yeah. What do you find more difficult to treat? I think I already know the answer. What you're going to say, Charco or osteo?
Difficult, Charcot.
Yeah.
Yep, difficult. Will never be the
And
same.
yeah. Yeah. What diagnosis did you have with a patient that surprised you the most?
Hmm. Patients who are on hydroxyurea and they were just had these non-healing ulcerations. So don't forget to check medications and certain medications that cause non-healing.
Oh, wow. And what one mentor who influenced your career?
My chief of podiatry, Dr. Stephen Durazi. He was
I knew
one
it.
of my mentors and taught me so much throughout my residency and even after residency. So I owe a lot to him.
Mhm. I knew you were gonna say that. Yeah, no, this is okay. Yeah, I believe. And I think that's all the questions from rapid fire.
Okay.
Yeah, so yay, you survived! Yay!
I know. I was scared. I was like, oh.
No, no, no. But you know something? Dr. Armstrong was saying how you have to find your like BFF, best friend for life
Yeah.
or something like that. And when he said that, I first thought of you, Dr. DeJesus. Even though we're not like close like that, I was just
Yeah. Yeah.
like, Dr. DeJesus is the person who I like ask questions or like, if
Yeah.
I had a
Call a friend.
problem.
Call a
Yeah.
friend. Yeah.
Yeah,
Yeah.
yeah. And I was like, oh, it's Dr. DeJesus. But
Yep.
I mean, anybody who's listening, anybody who gets trained by Dr. DeSeuss, you're golden, and
Oh, thank you.
that's a fact.
I
So
appreciate that.
I wouldn't be here. I wouldn't even be
I,
talking like this. I wouldn't even be on this. Yeah, if it wasn't for you, I'm being like 100% honest.
oh,
Wouldn't be. Yeah. You,
I am proud of you.
yeah, yay.
Those are things that make me happy to see others thrive who I've trained.
Yay.
So I appreciate all those kind words, and it makes my heart happy.
Yay. So, Dr. DeJesus, thank you so much for joining us today and sharing your incredible knowledge and experience in limb preservation. One of the biggest takeaways from today's conversation is that every diabetic foot ulcer deserves respect and care. And big thank you to Dr. DeJesus. Thank you so much.
Thank
Dr.
you.
Yay. And no, I'm being honest, if anybody has a complicated case, like a super weird complicated case, Dr. DeSuze.
Yeah.
She's the one. She really is the one. Even if you have to travel to another state, she's definitely the one. I have 100% sure about that. Okay? So it's
Thank
truly been
you.
a pleasure. And this has been LIMBWatch with Diabetic Foot Files. I'm Dr. T. And take care of your feet because they take care of you.
Yep. Appreciate it.